Question was, in pterygium, elastotic degeneration occurs in which layer? Your options were epithelium, endothelium, Bowman's layer, and Descemet's membrane. So answer is clear, Bowman's layer. So first of all, it's easy question repeated many times. This is a pterygium. Okay. Also, another name of pterygium is surfer's eye. Some important things that you should remember regarding pterygium is, can you see here this mass with these blood vessels? So it's a wing shaped fold of conjunctiva that is encroaching the cornea. So two important terms, encroaching cornea and fold of conjunctiva. More commonly it is seen in tropical climates. This is 3 o'clock position, this is 9 o'clock position. So it's more commonly nasally in 3 o'clock position, though even it can be there in the 9 o'clock position. So histologically we can say that it is degenerative, elastotic, vascular, granulation tissue. With destruction of Bowman's membrane. As you can see here, it has three parts, 1, 2 and 3. You can say the part 1 is head, part 2 is neck, that is at limbus, and part 3 is the body, that is at conjunctiva. So three parts are there, head, neck and body. Now sometimes what you get is line, a line here near the edge of the pterygium where there is a iron deposition. So another question that can be asked, that the iron deposition line in pterygium is called Stocker's line. Very important. Now how to basically treat this? How to treat the pterygium? This was a question asked in AIMS. So one thing is, what we can do is we can remove the whole of this piece. Okay, so we remove the conjunctival fold at cornea, at the limbus and the body. So this is called a bare sclera technique, where we remove whole of the conjunctiva and the sclera remains as such. So this is called bare sclera technique. The problem with this technique is there is a high rate of recurrence. Up to 80% in some studies, this pterygium comes back. So what to do now? So what we can do is we can take a small amount of conjunctiva from other piece, maybe from that eye only, or from the other eye, or from a cadaver eye, and put that in the area of the bare sclera. So that is called a conjunctival graft technique. Also what you can do is you can use mitomycin or amniotic membrane graft. Sometimes not only the Bowman's, the stroma is also involved in the region of cornea. So here when you remove it, you get a very deep defect in the cornea. So in these cases what you can do is you can use a lamellar patch graft. This was also a PGME question. So this is the means that you take a part of donor cornea and put it in the region where there is a defect. So these are the things that you can do as a treatment for the pterygium. Now another question that was asked is an inflammatory condition that can cause a lookalike term or lookalike lesion like pterygium. We call it pseudopterygium. So what are the important features? So first is basically it's not a true pterygium. It's just an inflamed conjunctiva that gets attached to the cornea. The second thing that you have to remember is that what can cause it? Definitely anything that can cause the inflammation of conjunctiva, like in chemical injury, you can have it in thermal injury, you can have in any conjunctival surgery that is going on, maybe let's say buckling surgery for retinal detachment. You can get in Stephen Johnson syndrome, in ocular cicatricial pemphigoid, or in any type of intraocular surgery. As I told you that the pterygium occurs more in the 3 and 9 o'clock position, the pseudopterygium can occur in any position. My clinical experience says that it is more common in the superior and inferior. Now, an important test that can differentiate between the pterygium and pseudopterygium is the probe test. This also was an AIMS question. Now, there is a difference of opinion regarding probe test, that where probe test is positive and where probe test is negative. So earlier what we used to do is that we used to put a probe, it's like a glass rod, just beneath the just beneath we put a glass rod just beneath the fold of conjunctiva. So what it says is that the probe test is positive, that probe can be inserted beneath the pterygium, but it is negative in pseudopterygium because there is an inflammatory adhesion. Now there is a controversy in two books. One says that probe test is positive in pseudopterygium and one says that post probe test is positive in pterygium. But for now, as I can say from the available literature and according to the reference of Dr. Samir Basar, who is a master of the corneal surgeries, so he has written that it is positive in pterygium and negative in pseudopterygium. But Khurana sir book says the opposite, like it is positive in pseudopterygium and negative in pterygium. So I would like to go with the Dr. Basak opinion right now because I also think that if there is a adhesion, if there is a fibrosis in the pseudopterygium, we cannot go inside. And sometimes when we do a surgery of pterygium, we feel the fleshy tissue is there, but definitely there can be small space then get be created by the probe. So for now, definitely probe test is done to differentiate between the pterygium and pseudopterygium. A bit of controversy regarding in which it is positive or negative, but for exam purposes, I would say go for positive in pterygium and negative in pseudopterygium.